Hello for the week. This is our lecture on healthcare rationing. You guys have been indirectly discussing this in your group discussion number 2 when we have our healthcare society, in which each of you played a character, and we're trying to dole out the limited amount of healthcare dollars that we have for our society. And I'll be bringing up some of the characters as we go along, fully to discuss some of the points that we're making here for healthcare rationing. So the idea behind rationing, very briefly, is that we have limited resources in healthcare spending, and we have to make decisions about how to use those resources, and therefore we ration them. So in contrast to this is the idea that healthcare is a human right. We have a lot of people saying, well, people deserve health care, right? If you're sick or ailing, you deserve to have it fixed. Isn't that the way it should be? This is the basis of a lot of our values in society, that when in need, you should get help. However, there are limits to this. Based on our own public insurance programs, the money that people have to pay out of pocket for things, and in different healthcare systems, we have things like waiting lists and things like that, if you need it, you may not be able to get it right away or get it at all, depending on what it is. So when this happens, healthcare, the question of whether it's a human right or not kind of comes into question, I suppose. And that is it a right for everyone to have everything that they need, that they would like to have, to be in the tip-top shape, extend life? And this is where, again, the longevity challenge comes in. Is extension of life included in this? Is a human right? So these are a lot of questions that we ask as aging professionals, because in healthcare, in the healthcare rationing debate, age is a huge issue, because a lot of the factors which we will see that we ration by are really kind of proxies for age. Okay. So what is rationing? As I mentioned, it's basically doling out the healthcare dollars based on age for one thing, and a lot of other factors, right, that healthcare economists have decided. We have to make decisions based on these factors. This is going to make our dollar stretch the most. And the reason why we have healthcare rationing is that we have a scarcity of resources. So it's based on the scarcity principle. You have a finite number of healthcare resources, aka 12 points, right? Plus you have increasing healthcare costs. So you have people who need 5 points to have a good life for a longer time, as opposed to 1 point to sustain you. And this equals a healthcare crisis for us. So to give you a sense, in the Callahan article, I think he brought this up, that in Medicare, spending in 2011 was about $558 billion, and expenditures for older adults, to give you a sense, have outpaced economic growth for a while, for a number of years. So they're projecting that Medicare could go bankrupt in as soon as a decade or so, based on this idea that we have a finite number of resources and we're overspending those. So when we've driven up health costs, based on things like potentially extending life or expensive life-saving treatments or other things, and we haven't, put more in, or the healthcare resources haven't grown, that means that we have to take a look at what we're spending and ration it out, right? So the decision to prolong your life becomes an economical one, and also a social justice issue when we think about who gets what, right? So who is disproportionately left out of the healthcare dollars, and for what reasons? And that's where a lot of health disparities come in. And the bottom line is that with healthcare rationing, the questions become, can we afford it? And also, should we be affording this particular procedure based on the good of the many. So for those of you who are philosophers or have taken medical ethics, right, the good of the many versus the good of the few, these are a lot of principles, philosophical principles that we make decisions by, and ethical decision making, right? So this is just a reminder, I showed this last time, that older adult expenditures are a hefty amount of our healthcare dollars that are spent, which is probably why a lot of the rationing discussions are focused on that age group. We tend to equate older age with disability, and that disproportionately, leaves out some groups such as older adults in the discussion of who needs more money. So a lot of times in this, when we look at older adults getting such a large portion of the healthcare bucket, which there's no doubt that they should, given the fact that more disease and more disability does happen as you age, just by virtue of being alive longer. The question for a lot of people in society becomes, well, shouldn't this group have it more? Shouldn't we be spending more on kids? Shouldn't we be spending more on middle-aged people who have X amount of years of productivity left? Which comes up a lot in your discussions as well. When I think about Mr. Stroke, and you're trying to decide if this middle-aged man should have the best care or sort of more supportive care in sustaining life, but not having the highest quality because it's expensive. A lot of the arguments are about things like, well, he has a lot of years left. He could work. He could do these things. So we see that a lot. Mrs. Jones as well. We see some productivity kind of questions in there. And is the investment going to pay back, right? So what are some of the things in the book talked about this that we ration on? So it's certainly age, right? A lot of our healthcare decisions are based on age. So you get to a certain age then, and you don't get certain services. So an example of this would be in the UK, they deny dialysis past the age of 55. And that's based on a lot of complex, healthcare economics, and taking into account the effectiveness of dialysis and what it can get you past 55 versus other types of treatment that may be less expensive. But that's just straight across the board. You're 55, you don't get it. That would be an example of age. Ability to pay is a big one, and it was much more relevant for us before the Affordable Care Act, but that would mean basically you are rationed out of certain procedures or certain medications because you just can't afford them. And examples for this are often medication, because there are large copays for a lot of medications, particular ones for expensive diseases like cancers, brain tumors, macular degeneration, etc. So you end up with huge copays, and if you can't pay them, then you don't get it, and then that is, again, rationing by your ability to pay. We certainly think about productivity in society. A lot of things go into that, such as how long is this going to get someone, and which is related to quality adjusted life years in a lot of ways. How many years, without disability can someone have to be productive in society, to have a good quality life, versus how many years would you live with this procedure with continued disability. So obviously we're going to want to spend more money on getting more quality life years, right, than on not quality life years, because we want people to have quality life years. But, those are decisions that have to be balanced against, whose quality is more important, right? Is Mrs. Jones more important than Mr. Stroke? And what about Mr. Rogers? And is getting a transplant more important for him and having quality for twice as long, but it's less amount of time? You can see these come in. Some of the things that we certainly think about as a society at large, maybe not as individuals, is a cost-benefit analysis. So is what I'm paying for going to pay off? And the cost effectiveness is similar, but there are a few more things that go into, is this effective, than just how much does it cost versus how much does it benefit society? In cost effectiveness, we ask if the treatment provides our desired outcome for the least amount. So what is the most cost effective procedure in this list? Let's take, for example, Mr. Rogers. Is a transplant the most cost-effective way to do this, or can we get him there in an approximate way with much less money, therefore that procedure being more cost-effective? And when you think about a lot of these, I want to challenge you to look at these and think about how many of these are actually just indirectly age related. So even though we're not saying all of these are age, think about productivity in society, the anticipated effectiveness of a procedure, quality adjusted life years, how many years of quality life versus how many years of disability can we give this person. A lot of these do involve age. So this is a very important discussion for us to have as professionals. How are we spending our healthcare dollars? And, who are we then tracking back to, then who are we putting in charge to make these decisions, and what are they basing their decisions on? I wanted to bring up first come, first serve as well. So some of you may know this, but in Canada, they have a universal healthcare system, but a lot of procedures can be on a first come, first serve basis. And in other countries, this goes as well. So when you have a first come, first serve, you end up with long waiting lists, right? And then essentially, if you're on the waiting list for a procedure for too long, you could not be qualified for that procedure. It may not be effective anymore, or it may not get you as much bang for the buck. So again, those limited resources come to those who came first, and you may be waiting for a while to get what you need. And that also happens in other countries, not just Canada, but people who have that, whoever, sort of was in need first, who got here, we treat them, and then we go down the list. Just another way to ration. We have some examples. I'll focus here on, I mentioned the dialysis one in the UK. The hearing aids one is also interesting. The article that you read, right, is related to this. So people with mild hearing loss no longer qualify for subsidized hearing aids. Only those with moderate to severe hearing loss. So that was a decision, right, a cut based on do they have enough. It's probably based on cost effectiveness, and also thinking about, do they have enough quality of life with mild hearing loss to be able to suffice, but we have to focus our dollars on those people who need it the most, whose quality of life could be improved the most by hearing aids. One interesting thing that I would encourage you to look at for perhaps your healthcare policy paper, which I'll talk about in a second, is Germany. They have a very, very rigorous cost-effective analysis procedure within their healthcare system that makes a lot of their decisions. And a lot of people, when they're analyzing this, have some good things to say about how this is kind of shaking out in the rationing. But they have instituted across the board this. It's harder for people like us that have more of a marketplace economy where every insurance can be different, until you get to public insurances like Medicaid and Medicare, who act universally. So some of the examples of how we ration here at home, we don't have rationing, do we? Well, we certainly do. One thing that everybody really has is organ transplant rationing. So we don't have enough organs for everybody who needs them. And, Mr. Rogers certainly needed one. And I think that Jenny could have definitely benefited from a kidney transplant at some point. But these things are, we don't have just a plethora of organs and transplant centers and doctors who can do this, and medications to help, which are expensive to help transition. So organ transplants is definitely one way we ration here in the US. And if you don't know, there are regional lists for organ donors, for organ transplant lists, and they aren't just based on a first come first served basis. Don't get scared. They're based on a lot of things, and there are medical ethics boards that reside over them. But essentially, it's a mix of things like how severe your disease is, how long you've been waiting, etc., for an organ. Some interesting stuff, though, to look up and find out. How do they make decisions about organs? We also have the book termed Backdoor Rationing. So backdoor rationing is basically rationing sort of indirectly or by default. It's like through the back door. We're not doing it through the front door like, hey, you are on the waiting list, so you go there. But this is like the tricky rationing that actually happens, but we don't think about. And one of the big things here is ability to pay. Again, much more important when we had tons and tons of people not covered by any insurance, but there's still very limited coverage in a lot of insurances. So your ability to pay for a drug, a procedure, that is a backdoor rationing tool. It's not upfront. They're like, hey, you can have this, but you have to pay this $5,500 copay for that brain tumor drug. So, that does cut out a certain section, disproportionately affects a certain section of the US. And that could be people in poverty, people without money, people, and older adults certainly are in that category, but not all of them, obviously. About 10% of older adults, I think, are below the federal poverty line. So when we think about different diagnostic groups being rationed out of things, so whether or not you can get a procedure is based on whether or not you have a certain diagnostic code. So if you don't have one, you can't get it, or you can't get it, covered under insurance. Sometimes people aren't supposed to do this, but they dodge sickly enrollees. So again, this is another age thing. So this is back through the back door. We don't want this person. They're a little too sick for us. They're going to cost us a lot of money. I don't want them on my panel of patients. I'm going to refer you elsewhere, or I'm going to let you go elsewhere. And a lot of times those tend to be older or poorer patients who've had sort of not just healthcare disparities, but they've had sort of other types of disparities growing up poor or being older in society. Some other things that you've certainly heard of before, probably for backdoor rationing, would be if you have a pre-existing condition, whether something is quote unquote deemed medically necessary for your diagnostic group. And also when we think about older adults and things like qualifying for rehab, making steady and meaningful improvement is often a condition for staying and paying for certain conditions or certain types of things like rehab. So if you're not making what whomever has defined steady and meaningful improvement in whatever way, you're stuck with either being discharged or paying out of pocket. All right, so those are some examples of how we ration for sure in the US. Let's look at the rationing debate. So in your book, there is sort of a back and forth between, should we ration? How should we ration? What factors should we use? And for us, it's the most important argument that we're going to talk about is should we ration by age? So some of the reasons why we would ration by age is often associated with disability at times and quality adjusted life years. So how long you have left to live and how many quality years you have left. So most people argue based on things like disability and quality of life years left, and the healthcare. Also, why we ration by age is there are a lot of healthcare costs associated with extending life beyond, I know what Daniel Callahan had talked about as the natural lifespan, right? So extension of life for elderly patients is very, very costly. And it really doesn't have as much bang for the buck, right? We've been reading that in our articles on healthcare last week for Medicare Part Q and also Ezekiel Emanuel's article. So life-saving treatments technically are not very cost effective. Certainly they can extend your life by a small amount or help out a bit, but they don't necessarily buy you good time, right? So, and they're very costly. So thinking about the natural lifespan and having all the things that you can have within a natural lifespan, and then beyond that time, not chasing the cure, right? So sort of that Medicare Part Q type of healthcare. When we think about, when we think about a societal benefit as well to rationing by age, right, the argument here is that somehow society will benefit from the increase in productive years from those who then receive more resources. So what we mean by that is, let's think about Max in this case, maybe Max versus Mr. Rogers even. So who is going to benefit society the most for getting the best treatment? And some of you have alluded to this, but the argument here is for Max, because he's 32 years old. And if we give him a Cadillac treatment, he's going to be a productive individual in society for, 50, maybe 60 more years. 50, maybe 40, 50 highly productive more years. And for Mr. Rogers, we have just a few years left. So who should get the more treatment? So we look at societal benefit and age in that way, productivity, who can be the most productive or give back, and not just economically, but give back in a sense of touching others, helping the society as a whole. So why not ration? So some people say, well, for age, if we save money by cutting older adult funds, then there's no guarantee that money is just going to go to the most vulnerable population that most people think should get all the money, which is kids, right? We want more healthcare dollars towards kids as a society, but there's no guarantee that cutting up there is going to just make it so much better for kids. So why age? Also, there has to be other ways to ration besides age that are less just harmful across the board, that could help out in strategies like thinking about those different factors and thinking about allocating resources according to need and not just according to age, right? So who needs it the most, not who's the oldest. Also, the argument here is that this violates the dignity that we should be giving older adults and respect for individuals. And doesn't that violate their dignity and be disrespectful of people by just saying, hey, you're 55, you don't get dialysis anymore? In some ways, I think that this is a valid point, because we need to be mindful of doing things just to a certain age group, right? Because that's ageism. However, we also need to think about, some of these other factors. And is what Callahan is saying in his readings, by giving people all the bang for the buck that we can get within a natural lifespan, but not taking on these, sort of unnatural life extension procedures that aren't really giving you that much more quality of life. Is that really disrespect, or is that actual respect? So this is sort of, both sides can argue disrespect and, lacking dignity for either rationing or not rationing by age. And they also make a point that perhaps that we're looking at this too simply if we ration by age. There are a lot of other factors, so maybe we need to think about this as a broader discussion, and certainly most do. It just happens to be that age is a part of the conversation for most of those factors. All right, so that's the sort of gist of the back and forth between the debate, and you'll pick that up in the readings as well, of why we should or shouldn't ration by age. The bottom line I want you to come away from this with, though, is that there's a cost to everything, right? No matter if you ration by age or if you don't ration by just age, there are costs that need to be balanced. We can't ignore this. And if we decide to do it in this way, it's going to affect the group who doesn't qualify for that. So every decision that we make to cut funds is going to affect somebody. And chances are that older adults are going to be within that category. Just finding the ways to make that the best decision that we can for all age groups, including older adults, is the trick here. So we need to have rationing. It's not going to go away unless, somehow the world blows up and recreates itself and we don't have healthcare debt and a lack of resources. But we need to be mindful of the decisions that we're making and how that's disproportionately affecting certain groups, certainly. Okay, so I wanted to bring up the issue or the discussion for sure, and you guys have been doing a great job of talking about the costs and what decisional factors you're making these on, and who we should give the most care to. And we see a lot of the arguments for age and productivity and quality of life years coming out in your discussion. And I wanted to let you know that last night I went to Meadowlark to do this with mentors and the students who were on the in-person class, and they're bringing up a lot of the same points that you guys are, and they had a really hard time with this concept as well. And some of the things that we talked about last night were, again, things like dependence and productivity and responsibility to other people. We for Ms. Smith, who is the older woman who's 81, we had a long discussion about informal caregiving. And even though it's free, right, for now, there are anticipated increases in costs later on for informal caregivers who do have disproportionately poorer health, poor mental and physical health, a lot of the time just due to the burden that they have, as well as giving up their own productivity, right? So when we think about the argument for productivity, sure, Ms. Smith may not be able to be productive for more years or give back to society, but her daughter certainly has several years left, and we've limited her productivity. So these are the types of discussions that we're having with the mentors, and it was a good time. We generally had Jenny getting 2 points, Max getting 1 point. Ms. Smith got 0 points a couple of times, but got 2 points a couple of times. Mr. Rogers got a couple of points usually. Mrs. Jones definitely got the most points out of anybody, which isn't surprising when you look at the makeup of who she is and all of the things that she has left: quality of life years, productivity. She has dependence and responsibilities. She's a younger, middle-aged person, so lots of life left. And we also brought up some interesting issues around moral arguments about who should get treatment or who shouldn't. And it's interesting to me because in the past, when we talk about Max, we've had a lot of people give him the death card. I shouldn't say a lot. It's not like he gets the death card all the time. But a lot of people make the distinction that, well, we're less sympathetic to Max because he did this. This is a choice for him. He did this to himself versus, a Mr. Stroke who has MS and he didn't choose to have it, and his life could be very low quality similarly, but he didn't choose or wasn't an active agent in this. So we see a little hint of that in some of the comments that you guys are having, but it's definitely the moral argument comes into rationing a lot. Who deserves this, right? Sometimes doesn't necessarily come down to the cost effectiveness, the quality of life years, the productivity, but who's the better person sometimes. So anyway, I thought I'd share a few of those comments from our discussion last night.